Hi guys, this is Dr. T speaking, and this is Clinical Medicine with Dr. T. So guys, welcome to the channel. Welcome to this episode as well. So guys, I want us to finish heart failure. Let's finish about heart failure now. This will be our part 3 in heart failure management. So remember guys, so in heart failure, like we said, that the problem in heart failure is fluid overload. Fluid overload. So patients that come to the hospital, a patient who has got fluid overload symptoms. Fluid overload. So, and we said that this fluid overload manifests itself in the form of pulmonary edema, swelling of the legs, splenomegaly, hepatomegaly, ascites, all those portal hypertension symptoms, increased JVP, that kind of stuff, orthopnea, PND, all those. So these are symptoms of fluid overload. So when a patient comes in with heart failure, so what you want to quickly check is, yes, they are fluid overloaded, but what are their assets? Remember, with medical emergencies, we follow the call a cab. So you will call a cab as you'll call everyone to come and assist you. As someone is checking sets, the other person will be checking the circulation, meaning the blood pressure and the pulse. How is the circulation? Airway and breathing. If that patient is talking to you, you don't have to worry about airway and breathing. So you want to check their sets. Are their sets less than 90? If sets are less than 90, put them on oxygen immediately. Do your blood pressures. Insert a catheter. Insert an IV line, which you will use to give your Lasix. But we'll talk about this later. So when you check the blood pressure, let's say you find that your blood pressure, your systolic is less than 90 over 60, for instance, less than 90. That's the main thing. So which means here you've got a patient that has got a fluid overload, but on the other side, they're hypotensive. So you can't just give this patient Lasix, because the Lasix is good to cause them to urinate and all of that, to pass urine and all of that, but you will drop this guy further and push them into some kind of a shock. You don't want that. So if your blood pressure is low like that, remember the MAP, guys. MAP, mean arterial pressure. It's usually around 60. Some say 50 to 60. Some say 55 to 65. So around there. So MAP, the formula, there are so many different formulas, but I like this one. It's 2 times the diastolic blood pressure plus the systolic blood pressure divided by 3. So you get that. So the mean arterial pressure is the pressure at which organs are being perfused. So if you've got a hypotensive patient, but you are maintaining a good MAP, then you can be sure that your organs are being perfused. That's why in critical medicine, like in ICU, they are not really worried about a hypotension per se, but what they are worried about is the MAP. You can have hypotension and still maintain a good MAP. All is still fine at that point. So it's the MAP. So once you decrease the blood pressure like that, you are gonna get to a point where you've decreased your MAP, which is your mean arterial pressure, and you're gonna end up getting multi-organ failure from the hypoperfusion that was caused by the Lasix. So you don't want that. You don't want that. So if you've got a patient like this, fluid overloaded but severe hypotension, take this patient to ICU. Speak with someone who works in ICU to take this patient, because these patients, they need positive inotropes to help that heart to, because basically they're in severe cardiac shock. You see? So you want them to be given positive inotropes, like your Doputrex or dobutamine, and this is a critical patient, so it needs to be in ICU. Yes, they will introduce the Lasix later on, but it's not a patient that needs to be managed in A&E and be sent to the ward. It's a critical patient. Or you might find that by the time they are already here, their MAP is already down and it has been down, and they've got altered mental status, and they might need intubation, because if they've got altered mental status, low GCS, you need to protect the airway, and the only way to protect airway there is to intubate that patient. So that's a complicated side of heart failure. So never be shocked when you see a heart failure patient being intubated. It's because of these reasons. So let's say now the blood pressure is normal, but they are fluid overloaded. What do? Your drugs there are your diuretics. That's what they need at that point. Diuretics will give them symptom relief, like instantly. Within an hour, you will already see a difference. So you give them diuretics. It's Lasix, the best one for heart failure. And so you take them out of failure. As you do that, you will work them up and try to find out why are they in failure. Is it because they are not taking their medication, so it's a compliance problem, or is it because of the diet that they are not adhering to a diet advice, like so low salt intake and low fluid intake and all those things? And is it someone who is who has got other comorbidities? Is it someone who's got a chest infection now? Are they having a pneumonia now, or are they having a UTI? What is happening? So are they having any sort of infection? Because any infection basically can put a patient into failure, because infection demands a lot from the body. Metabolically, there are so many changes that happen when you've got an infection. So, and that's not their homeostasis. So you want to look for that. Look if they are anemic. So you do your FBC, check if they've got white leukocytosis, if they've got anemia. Remember, anemia is one of the causes of high output cardiac failure. So a patient develops anemia who are already in failure, that's bad, because anemia alone does give a patient a heart failure. So look at things like that, and so you want to find out the cause, and then also manage the cause as they go to the ward. When you go to the ward, you keep them. When they become asymptomatic, you can switch to oral medication, switch to oral diuretics, and they need to tolerate and be asymptomatic for 48 hours on oral before you can discharge them. And you introduce your antifailure treatment. Antifailure treatment, most of the times they are still given even in the A&E when they come. It's not a big issue, but its effect you cannot appreciate them now. They are always long term. So, but what they need at that point is that Lasix. So you admit them and manage whatever that was the problem, and then you discharge them when they can. They must be completely asymptomatic, and also they must be able to tolerate your oral diuretics. So that's that. So, and we spoke about the drugs of choice when it comes to antifailure. Remember, heart failure has got this: it's diuretics and antifailure treatment. I've seen a lot of patients that are just on a diuretic combined with a calcium channel blocker, and so yeah, you will see those kind of patients. So you need to introduce them. You need to give them antifailure, and we've spoken about antifailure drugs. That is it's your ACE inhibitors, it's your beta blockers, it's your guys. Why are beta blockers counted as antifailure drugs as well? This is the reason. We have spoken about ACE inhibitors, ARBs and the ANIs, ARBs and the ANIs. We don't have these ones in South Africa in the private sector yet. The drug that we have, we've got carvedilol here, we've got enalapril here, ARBs. We also have ARBs. So your Satans. So these are your anti-failure drugs, and it's best that you combine 2 at a time, because remember, personally I would manage my patient with 2 of these. If they can't tolerate this, I put in ARB and see how will they do. So maybe they get angioedema and all that. Go to the video about and watch antihypertensives where I speak about those drugs. So the reason why you put a patient who's got heart failure on a beta blocker is this. BP is equals to cardiac output multiplied by the peripheral resistance. So we said that in heart failure you have a problem of this. You've got a chronic reduced cardiac output. So if you've got a state of a chronically reduced cardiac output, the body will want to correct that. And one way of increasing cardiac output is increasing heart rate, according to this formula, as you can see. So, but we know that our cardiac output is because of a pumping failure. So increasing a heart rate is not really going to help, because what's going to happen is the body will want to increase this cardiac output and increase the BP. So what the body is going to do, catecholamines are going to come in and stimulate the beta like your adrenaline, your norepinephrine, your epinephrine. So they'll come in and stimulate beta 1. Once you stimulate beta 1 receptors, you are going to cause an increase in heart rate. Once this guy goes up, your cardiac output should go up. That's in a normal patient, it should go up. But the problem is that in heart failure, you have a pump failure. So even if you can force this heart to beat 200 times per minute, because that's what's going to happen now, you're going to increase the heart rate, which is like a number of so you're going to increase your heart rate. Instead of a heart beating at 100 per minute, now your catecholamines are going to push it to beat 150 times or 200 times per minute. That's not good for a failing heart, because basically you are saying to this heart, yes, work, but you're not giving it time to rest and be perfused. Remember, perfusion of your heart muscle happens during diastole, during relaxation. So if the heart is beating, if you've got tachycardia, like the heart is beating maybe 150 per minute, it means now you have reduced the relaxation time, which is your diastole. You have reduced that. So if you have reduced that, it means now you're not giving it enough time to get that blood, to get those nutrients, to get that oxygen. So you are saying to this heart, I want you to work, but I'm not going to give you sufficient blood, energy, glucose and oxygen to do the work. So you run a risk of having ischemic heart disease here, forcing ischemic heart disease. Remember, ischemic heart disease do not only come because of plaques only, atherosclerosis. You can cause that even here, because remember, you have now a dilated, a hypertrophied heart. That small artery that is supplying that hypertrophied, it's easier for an artery to supply this area. But now if there's hypertrophy, it means now that same artery must supply this area. On top of this, that has already happened, you are saying, I want you not to relax and always be working. So beta blockers, they sort of like slow down the heart rate and say, okay, it's fine. We know that we've got a decreased cardiac output, but overworking per minute is not going to help us. So you give beta blockers to slow that down. So that's why we give beta blockers to heart failure patients. Another thing that I want to quickly and lastly that I want to explain is that we said that in heart failure we don't want the rest system to be activated. This chronic activation of the rest system, we don't want it. And we have said that the drugs that deactivate this are the ones that we were speaking about. Your ACE, your ARBs, your ANI, and your mineralocorticoid receptor antagonist, which is aldactone. So we know that, okay, this is what I want to explain. When you've got a patient with heart failure, you give them Lasix. If you give them Lasix and you combine your Lasix with an AC inhibitor, studies have shown that you don't have to supplement these patients with potassium. Remember, Lasix is a potassium wasting drug. So patients will become hypokalemic when you give them Lasix. But studies have shown that when a patient is on an AC inhibitor, you don't have to give them supplements. That's point number one. Point number two, when you have a patient that is taking Lasix and aldactone or spironolactone, you don't have to give them potassium again, because this is a potassium sparing. As much as you've got a potassium wasting, but here you've got a potassium sparing drug. So those patients should not be on a potassium supplement as well. And why is that? Remember the renin story. Renin released converts angiotensinogen to angiotensin 1 into angiotensin 2. Angiotensin 2 now goes to the adrenal glands and cause the release of aldosterone. Aldosterone is now going to go to the kidneys and cause reabsorption of potassium, and water will follow. Sodium. So aldosterone is going to cause a reabsorption of sodium, and water will follow. Remember, sodium is a proton. So I want you to get why is aldactone a potassium sparing drug. So when you are gonna this is aldactone. This is what aldactone does. This is what it does. So, and then it causes fluid overload, reabsorption of water. But if you give aldactone, which is an antagonist to this, you are blocking this thing. Remember, when you reabsorb a proton back to the body, in order to maintain an electrochemical gradient, you need to let go of a proton as well. And that proton that goes to the urine happens to be potassium. So now, if you come in and you give it, this is a normal thing that happens with the rest system without any drug involved. But if you involve aldactone, now you give aldactone is going to come and interfere with the reabsorption of sodium. So now the sodium that is supposed to be reabsorbed, it goes to the urine. So you lose sodium when you give aldactone. But because of that principle that we need to maintain electrochemical gradient, potassium is going to go the other way. So that's why aldactone is a potassium sparing drug and has got a potential of causing hyperkalemia. I hope you get that. So these patients should be monitored. Whenever they come, they should be done UNEs to check their potassium status. So guys, that's heart failure. Thank you for watching. Hope you enjoy. Thank you.